Are you ready to shock somebody? Clear. All right, this is defibrillation. So if we look at the chain of survival, just like any chain, it has links. And if a chain is broken, then the chain doesn't work. So if we can implement these things sooner, the person has a better chance of survival. So the first thing is early recognition that there's a problem and calling 911. If we can do that, then the person has a better chance of survival. Early CPR and early defibrillation, right? Those are important. The better person has a better chance of survival. And early advanced life support from the paramedics or bringing them into the hospital and getting that care, right? And then the early post-cardiac arrest care, like rehabilitation after, and that will actually help the person have a better chance of survival. Okay, so that's the chain of survival. So now defibrillation. Defibrillation is the process of taking electricity and putting it through the heart to clear all the charges out of the heart so that the person can start to have a better beat. So we clear all the charges out and hopefully their pacemaker starts firing again and starts functioning again and they take up a normal rhythm. Okay, I'll show you the rhythms in just a couple minutes. But defibrillation, that's the process of taking that electricity, sending it through someone's body, through the heart to clear all the charges out. All right, so then the automated external defibrillator, then that is what we're going to use. So this is an AED, an automated external defibrillator. So it's automated. It lights up, it talks to us. It's external to the body, so that means it's not the kind that's implanted under the skin, but this is an external device. It's up on the wall like a fire extinguisher. And it's a defibrillator, that it will reverse fibrillation. So that's pretty cool, an automated external defibrillator. So now you can say, go grab the automated external defibrillator and report back to me. Most people just say defibrillator or they say the AED if the person knows what you're talking about. All right, so now we can call for the defibrillator and know what we're talking about. Okay, and where can you find the defibrillator? It can be found in grocery stores, sometimes gas stations, any public place like a community center or an arena, you'll find a defibrillator. Sometimes people might carry a defibrillator in their car or in their trunk. Definitely the prices come down on defibrillators, so you can be able to access them and just get one for your house if you want to. Okay, so a defibrillator will have, the site that has a defibrillator will have a sticker on the door that says Public Access Defibrillator Site, a PAD site, knowing that, so you know that now there's one that's public access. If someone has a cardiac arrest, I can grab it off the wall and use it in a rescue. And you also know that there's people there that are trained to use the public access defibrillator. Okay, so start looking for those, the heart symbol with like a lightning bolt going through it, or like a heart looking like it's getting zapped by electricity. That's the symbol to let you know that that place that you're in, that community center, actually has a defibrillator on site. All right, so that's pretty cool. So that's our automated external defibrillator. So let's look at 4 different rhythms that we talk about in this class. There's rhythms that are shockable and rhythms that are not shockable. Okay, so if you take a look here, let's start with the normal sinus rhythm. That's a normal rhythm. It doesn't need a shock. It's normal, right? But it does show the electricity, how it goes through the heart. So the first little bump is the atrium's contracting, and that big spike is the ventricles contracting, and then the other part is kind of the reset. Okay, so it's like atriums, ventricles, reset. So we can look at it that way. You actually don't need to know any rhythms to be able to work the defibrillator. So that's pretty good. You don't have to analyze or make any complicated decisions. You actually looking at the rhythm and making the decision whether you have to shock. This will actually analyze it for you and tell you whether it recommends a shock or not. And so it says shock advised, then you press the shock button and deliver the electricity. Okay, so the normal rhythm, we're not going to shock that. We're also not going to shock flatline. But wait, didn't you just see yesterday on TV where they shocked flatline? You probably did. We actually can't shock flatline. Only in Hollywood do they shock flatline. You know, you see the movie, the person's normal sinus rhythm, all of a sudden they go immediately flatline, boo, and then they bring in the paddles, clear, and they shock them. Well, in real life, we don't do that. So there's only two shockable rhythms from a defibrillator. And if you look here, you'll see the two shockable rhythms: ventricular fibrillation and ventricular tachycardia. Okay, so everyone say ventricular fibrillation. All right, did you say it? Ventricular fibrillation. Okay, that's one shockable rhythm, and the ventricular tachycardia is the next. So tachy means rapid, and cardia means heart, and it's in the ventricles. All right, so everyone say ventricular tachycardia. Ventricular tachycardia. All right, so the ventricular tachycardia is a rhythm that's shockable as well. So if we look at the ventricular fibrillation, fibrillation is a quivering. The heart will just be quivering like a bowl of jello. Okay, and the ventricular fibrillation, it'll be opening and closing so rapidly that only a little bit of blood comes in and only a little bit of blood is ejected out, but it's actually not enough to feel a heartbeat. Okay, so then this person is clinically dead. Okay, so let's just take a look at the anatomy. Before we get to the rhythms, let me take a look at the anatomy of the heart, how everything functions. Okay, so you see in the picture that there's the brain, all the blood supply down to the heart, you see the lungs, and then you see the blood going to the lower part of the body. So this is how blood would flow through the body. So first, blood comes back to the heart on the right side of the heart. So you're looking at me, this is my right side, this is my left side. So we're looking at the picture in the same way as if you're looking at the casualty's heart. So blood will return back on the right side of the body, okay, from the head and from the toes all the way into that right atrium. So atriums are reservoirs, and the ventricles are the pumps. So the reservoirs collect blood coming back, and the pumps pump it out of the heart. So it will come back on the right atrium, and then it will go into the right ventricle, and the right ventricle will pump over to the lungs. Right? At the lungs, the blood will pick up oxygen. So earlier we said that one red blood cell will have 4 oxygens bound onto it. And so it will pick up oxygen and it will come back to the left side of the heart now, the left atrium. So that left atrium will then allow it to drain, it'll contract to allow it to drain into the left ventricle, and the left ventricle now is that big power pump. So if you look, you see how the right atrium, right, the wall is very thin, but take a look at that left ventricle. That left ventricle is very, very strong, right? So you see the center wall being thick, and you see that left ventricle is really thick, but that right ventricle is not too thick because it only has to pump from the heart to the lungs, heart to the lungs. But that left ventricle, it has to pump all the way up to the brain and all the way down to the toes. So it needs to have a lot of force, a big thick wall to be able to pump that blood out of the heart to be able to do that. Okay, so that's how the electricity will actually flow through the body. Is if we look at the picture in the center, it goes atriums, coming down, and then ventricles. Atriums, ventricles. So let's look at the electrical system. The electrical system has the SA node. Your primary pacemaker is your sinoatrial node, SA node. Right? It's a ball of cells that generates the electricity. It's the primary pacemaker. So it will fire all around the around the atriums, and then the atriums will contract. And it sends electricity all the way through to the AV node, the atrioventricular node. And the AV node is there, and it will send the electricity down the wall and all the way around the ventricles, and the ventricles will contract. Right? So it's atriums, ventricles, atriums, ventricles. So we're seeing a picture here that's really flat, right? It's a flat heart. But I want you to think about the heart as actually having depth to it, right? So it's the atriums not just going on the top, but the electricity goes all around the atriums, and the atriums contract. Then it comes down to the AV node, and then it sends it down the wall, but also around to the ventricles, and now the ventricles contract. Right? So atriums, ventricles, and that's what actually creates that pulse that we feel. All right, so feel your pulse right now on your carotid artery. This is the closest blood vessel that we feel to the heart. Another pulse that people check is actually the heart hitting against the rib cage. We call that the apical pulse. Right, but this is the blood hitting against your finger, basically. Okay, so that's how we can feel that left ventricle pumping and pumping the blood to hit against your fingers. All right, so that's how blood flows through the body, and that's how the electrical system works as well. So then if we're looking at the rhythms, right? So we see that this is the two shockable rhythms, ventricular fibrillation and ventricular tachycardia, and the two non-shockable rhythms would be normal sinus rhythm and flatline. So as good as you can get is normal sinus rhythm, and as worse as you can get is flatline, no electricity in the heart. Okay, so we're going to send that electricity through when we want to clear the charges out during a fibrillation, a quivering. And we're going to send the defibrillation electricity through the heart when someone is in ventricular tachycardia and it's opening and closing so rapidly that it's not even enough to generate a pulse. That person is clinically dead. Okay? So then if we look at how the operation of the defibrillator works, internally you're going to have, you have your shock button and you have your on and off button. You have your spot where the pads will actually be plugged into. Okay, there'll be a screen on it, or it will be able to, a speaker to be able to talk to you and tell you what to do. And internally, you could have like a SIM card, basically a recording card, like an SD card that would go into the unit, and it will actually be able to record the person's heart rhythm. It will record during CPR your mechanical compressions, and you can actually see what heart rhythm the person was in. Right, so that's pretty cool. So if you ever want to do some research, then you can just put that card in. You can be able to follow the person's heart rhythm all the way through the call. So that's pretty cool. It doesn't come with that card, but you'd have to order that separately, most likely when you buy your defibrillator. Okay, so we have the different buttons. We'll also have some things that are inside the defibrillator pack as well. So we're going to have our pads. Okay, so here's one set of pads. We see it's on blue plastic. So when I see these pads, I know this would come from the LifePak CR+. So we have the pads that show us where, the pictures show us where to put the pads on the chest. So normally we put pads on the upper right and the lower left. Right, so try that on yourself. So show me the upper right and show me the lower left, just underneath the armpit. That's where we're going to put our pads. There's other alternate pad placements. I'll show you those as well, but these are the main locations of where we're going to put the pads. This one shows the upper right pad. This one's going to show the lower left. So these are real pads, so I'm not going to stick them to my chest right now because these are real pads. They'll really stick. Another set of pads from like a LifePak 500 would be, you know, they're pretty big. And we see the other side, they have the sticky gel on that side. So you would actually peel it off the plastic and then stick it to the patient's bare chest. Okay, and that will show you a picture on the front of the pad of where to put them. Also, we can have some pediatric pads. So the pediatric pads usually come like in a wrapped up in like a pink wrapper to let you know it's for pediatrics, and then you'll have different color pads, like this, a pink one and a yellow one, and so it will show you where to put the pad. So on a pediatric, we're actually going to pick one right in the center, right on the breastbone, and one right in between the shoulder blades. So that's going to be the choice for our pediatric pads. Okay, but I did want to show you this box will only be found on pediatric pads. It's called the dose attenuator. So this will attenuate or decrease the dose. So when we plug it into the machine, that full adult shock will come to this box, and this box will actually turn it down or dim it like a light switch. And then there'll be less electricity that gets out to the pediatric. So that's a pediatric pad. We only want to use pediatric pads on a pediatric. We never want to use it on an adult. But we can use adult pads on the adult and adult pads on the child and the infant. Okay, so we never want to make the pads overlap. We always need space between the pads. So when we go through the guidelines, I'll show you that. We always need at least an inch between the pads. So if your pads are so big on an infant that they overlap, then you can't use those pads. All right, so on the infant, we're going to put one on the front, one on the back. But if the baby is just so small that there's not an inch between the pads, then you can't cut the pads or anything. You just can't do defibrillation. You'll just do straight CPR until you get to the hospital. Well, the paramedics will come and pick them up. All right, also inside the unit, we're going to find some kind of napkin to wipe them down or a cloth. We're going to find some type of face shield, right, to be able to put over their mouth to breathe. And then we have our scissors, right? So the scissors are there to be able to cut the shirt off and cut the bra off. So another face shield that you could use is this. The face shield, you would just carry this right on your keychain. And the way you'd use it, you'd open it up and you see that there's a one-way valve right there. That one-way valve is where you're going to put your mouth to be able to breathe for the person. All right, so you'd put it over their face. You'd wrap it around their ears. You would pinch their nose, and you would put this one-way valve right over their mouth, and you would give her breath right on the one-way valve. So that's pretty cool. That's a face shield, but you still do have to pinch the nose when you're using it. All right, so that's what you'll find in your defibrillator package. All right, so now I think we're ready to move on to the next steps. So when we look, we're going to put a pad on the upper right and the lower left. That's our normal pad placement. But you also know now that we're going to put one on the infant right in the center of the chest, and we're going to sandwich them, one right in between the shoulder blades. Okay, I'll show you two other pad placements as well. So if this upper right pad, here's upper right, and then the lower left. So if the upper right pad, if there's like an open wound there or a pacemaker or something, we want to move it away. But if there's no room to move it, we're going to move it to the back. But we're actually going to put it not on the shoulder blade, but drop it just below the shoulder blade right around the back. And then this pad will stay in that position. If you need an alternate pad placement for this one, there's an open wound or a big burn, a second-degree burn, like a big blister or something there, then we would move that side pad around to the back as well, but it's just below the shoulder blade, keeping it on the left side. So this one stays on the right side below the shoulder blade. This one stays on the left side below the shoulder blade. Okay, so those are 4 different pad placements now that you know to be able to attach it to someone's body. Okay, so then like I said, we can use adult pads on the adult, the child, and the infant, but we can only use pediatric pads on the pediatric. Okay, and it will say what ages to be able to use it on the pad case. Okay, so if you see this slide, this kind of shows the pads connected to the chest and how deep it might get. So we never want to put the pads close together because then you're not going to get a deep shock. Because remember I said the heart is not just flat, right? The heart has volume to it, right? Depth to it. So we want to be able to get it deep enough to be able to get to the back of the heart, the ventricles, right? The atriums on top, ventricles on bottom, but we also want to get it deep too, right? Down to the back of the ventricles, the back of the atriums. So we want to be able to get the back of the heart too. So it needs to be further enough away that the shock will go deep enough. And if the pads are too close, it's not going to go as deep. So let's talk about some special considerations. So if we look at the special considerations, we have shocking on a wet surface. If you can step down in water splashes, way too much water. So you need to drag them onto a backboard or onto the cement where you can shock them safely. Okay, so get them out of the water onto a dry surface. Then we have the metal surface. If you're shocking on metal, that's dangerous. I would never shock on a metal surface. Sometimes they say that like a metal platform or grating might be non-conductive. Don't shock on any metal. Just drag them onto a backboard or onto the grass and on the cement and shock them there. Okay, so then a pacemaker. If someone has a pacemaker that's implanted, usually they put the pacemaker on the left side, just below the collarbone. So you'll see like a York peppermint patty or like a roll of toonies, right? A couple toonies stacked on top of each other. It'll be a raised hard area, and you'll know that that's where the pacemaker is actually implanted, just underneath the skin, but sitting on top of the rib cage. Okay, you're going to move the pad 1 inch away. So if it's on the left side, you don't worry about it because this pad's going to go on the right and this one's going to be lower. But if there happens to be a pacemaker on the right side, then that's going to be right where you want to put the pad. So you want to choose that alternate pad placement. Okay, but the guideline says you can move it 1 inch away from the pacemaker as well. Okay, so then we have oxygen. If it's a high oxygen environment or you have the oxygen tank there, just move it away from their face when you shock. Okay, so then for medicine patches, if someone has a medicine patch right where you want to put the pad, you're going to peel the medicine patch off and take your napkin and wipe it down, or the clothes and wipe it down, and then you can put the pad in place. If the casualty is hypothermic, so they're too cold, then this is the only time in the program where we're going to limit the amount of shocks. Okay, so if you're a paramedic, some paramedics would have another guideline of when you're going to limit the shocks, but in our program, there's only one time we're going to limit the amount of shocks we give, and that's for someone who is hypothermic. They're too cold. Their heart's cold too, and their heart's just not going to get up and start beating fast again. So we clear the charges out once, if it's appropriate, and we shock them if it says to, and then we can turn our unit off after that. Okay, so then if they have an implanted defibrillator, right? Defibrillators are not as big as this one when they're implanted. They would look just like a pacemaker. So you would see like a pacemaker implanted, but then all of a sudden you see minor contractions in the chest. So not a full seizure, but minor contractions in the chest. When you're about to shock, then that you know that their defibrillator is shocking them on the inside. Okay, so also if someone is pregnant, then we are going to treat them just like it says. We're going to treat them with no change. We're going to treat them just like any adult, because if the mom doesn't survive, the baby's not going to survive either. So we need to just shock them with no change. Okay, so then our steps. We're going to first turn on the unit. Then we're going to put the pads on the patient's bare chest. So we need to expose the chest and put the pads in place, right? Dry shave them if we need to. Put the pads on, peel any medicine patches off, move pads an inch away if there's a pacemaker or a defibrillator that's implanted, right? And then we need to plug the pads connector next to the flashing button, and then it will analyze. And it will do all the work for you and analyze to say whether a shock is advised or it's not advised. So if it finds ventricular fibrillation or ventricular tachycardia, what is it going to say? It's going to say shock advised. And if it finds normal sinus rhythm, flatline, or any other rhythm, it's going to say no shock advised. All right, and so that's all the theory that we need to know for defibrillation. Okay, so let me run it from top to bottom, and I'll show you what I expect from you.